still good.
Oh,
hey guys.
cute. Good morning.
Good morning.
Hello,
We have
Bridget.
a very young participant.
This is my new one.
Oh.
And check him out. He's in merch. Wait, I gotta show you. He's got a Brain Turn 2.0 shirt on.
No way. Oh my God, that is awesome.
He's mad.
I mean, I know he's excited about cardiovascular prevention.
He's very excited. He's starting very young.
Yes, and that's what we recommend.
Yeah.
So small.
He's very small.
He really was very small.
Yeah, he's about 5 days old now. So
Aww.
I'm obviously at home. I'm not at work today. But I wanted to sign in. Are we at 8 o'clock? Can I get going here? 9 o'clock, whatever.
At 9, yes.
1 minute, yeah. So we're at 9, and I wanted to say welcome to Eugenia Gianos, and yeah, it's a pleasure to have you on. This is part of our it's a combination session here. A little bit about preventative care. Want to definitely get medicine involved and discuss kind of treatment and prevention and what you do, but also when we first did the original Brain Turn session, we were shocked at female participation, women in medicine. We had 84% women when we looked at the data from the original session. And we realized that this is something that's immensely important to the future of what we do, and kind of very in line with what our theme was for the whole session and the whole 4-week process. And so we wanted to create a separate session for people who have really demonstrated huge success and can be inspiring and serve as an inspiration for women everywhere. And so thank you so much for being a part of this.
Thank you.
And I'm sure everyone's going to have a blast, and I can't wait to hear it. So
thank you. Absolutely.
And we're starting them young here. Brain turns.
That's an early development career right
there. Yeah, exactly. All right, take it away. Thanks so much.
Thank you. All right, thanks for having me, everyone. And I'm so excited that, everyone has an interest in this, because really, even in cardiology, you'll hear at the end of my talk, there's an underrepresentation of women in our field. About 20% only female is what we know for the numbers for cardiology. So we're going to talk about that at the end, and how all of you are going to help me change those statistics. So we'll start though with, cardiovascular prevention. And really, this field is about what we call putting out the forest fires, right? So, you may have a blockage in one artery of your body, but the reality is this is something that's going on all over the body. And so we talk about really putting out the forest fires. So I'm going to start with some statistics. It turns out that by the year 2035, about 45% of the US population is going to have some type of cardiovascular disease. That's how common this really is. And one person dies every 36 seconds from cardiovascular disease, if you can imagine that. So this is very prevalent. This is what people are dying of. But again, these are just statistics. And for me, sometimes they just seem like numbers, don't really kind of hit home. And that was the case until, of course, one of my good friends called me one day when I was working on the COVID floors back in May, really busy, and told me that her 48-year-old husband went into a cardiac arrest. And this was shocking to me. I was, devastated. I couldn't believe that he could have possibly had something like this happen to him, particularly when what I do is prevent heart attacks. I'm like, this is something that we could avoid entirely. And, I've learned a lot through his experience with her, and really that is our goal. So what our mission is in this field is essentially to rewrite those stories so that you never get to that heart attack, to that stroke, to whatever that procedure is that you're going to need. And how do we do that? We do that through teams of people who take care of patients and target every aspect of what we call their residual risk, so that we can really holistically get everything under control and prevent any kind of event from happening. So this is the process of atherosclerosis. It's basically some plaque, soft, mushy substance that accumulates underneath the wall of your artery. It's cholesterol deposition. And it's fascinating how this does deposit, and it happens in all of the arteries of your neck, of your heart, of your legs. What happens is if that soft plaque ruptures, if there's a little break in that plaque, what happens is all these platelets or clotting factors come and stick to the area and completely block off the blood flow to, again, the heart, if it's a heart attack, to the brain, if it's a stroke, or to the legs, to the arms. It could be really in any part of your body. So these are some of the common risk factors that we all know about with respect to heart disease. We're very well aware that high blood pressure, high cholesterol, diabetes, family history, different things lead to heart disease. But I think it's important to realize there's other things that we're not always focusing on. Emotional stress is actually a major risk factor for heart disease. Inflammation in your body, even if it's from lupus or rheumatoid arthritis or some other process, sleep apnea, where you stop breathing at night, actually leads to increased cardiovascular risk. Going into menopause early, or even for women, something that's very fascinating is if you have preterm labor, or you have a small baby for gestational age, or you have preeclampsia or gestational diabetes, these are things that actually are associated with long-term risk of heart disease. So we're learning so much more than what we knew years before. And this is how we teach our patients, essentially, exactly with that diagram, because it's in one of our handouts. We show them what their risk is based on their numbers for different metrics. So we explain to them very specifically that if we can work with you to get your sugar, blood pressure, cholesterol, not smoking, of course, your weight, your diet, exercise under control in this target range, the chances of you needing to meet somebody from our teams who fix the arteries of the heart or the brain are very low. And that's what we work together with. We show them what their numbers are, we show them where their goals are and how we're going to get there. And one important thing to keep in mind is that that whole process of plaque in the arteries or cardiovascular disease is tied heavily to what we call cardiometabolic risk. So cardiometabolic risk is essentially when we talk about various things that all go together. Some of it is genetic and family history is related, can be contributing. But a lot of it is secondary, sadly, to a lifestyle that is prevalent throughout the world nowadays that is really suboptimal. And it leads to people being overweight or obese. About 66% of our country is either overweight or obese. Insulin resistance, where whatever insulin in your body, is in existence, is just not working. The receptors are not adequately able to use the insulin to target your sugar control. And that's tied to high cholesterol, blood pressure, sugar, inactivity, high blood pressure, inflammation, as we talked about, and really cardiovascular cholesterol markers being abnormal. And these are the most common ones we're aware of: the LDL, the bad cholesterol, the HDL, the good cholesterol. Way to remember that: lousy cholesterol, healthy cholesterol, okay? And triglycerides. All of these are the common markers that we look at, and people should really know what their numbers are for all of these. When it comes to genetic disease, this is something that I am fascinated by, and I take care of a lot of these patients. It's a genetically transmitted disorder called familial hypercholesterolemia. And the acronym I tell my students to remember is F plus H equals FH. That seems kind of obvious, right? But what that stands for is family history of early heart disease. So when you say, oh, my uncle and my brother, all of them had a heart attack at an early age, and you yourself have high cholesterol, we really should be thinking, okay, wait, could this patient have familial hypercholesterolemia? And the thing is that if somebody in the family has it, it is what we call autosomal dominant in terms of how it's transmitted genetically. So there's a 50% chance that if a parent has it, that their kid will have it. So what's important about that? If we recognize it in the parents, we can prevent heart disease in the kids. And it's really a fascinating disease. So you have, of course, you can diagnose it by different things. One is just your cholesterol numbers, your family history, whether or not you have heart disease at an early age. But these are what we call the physical stigmata of the disease, where you get, if your cholesterol numbers are so high, you just get cholesterol deposition in various places. So they have these little lumps here on their hands called xanthomas, or even if you feel the Achilles tendon, it's either thick or it has little lumps. And same thing here, you can see these are called xanthelasmas, where you have deposits. People can have these and it may not always be related to cholesterol, but very frequently in familial hypercholesterolemia, we do see that. And this is something called an ARCUS, where as you get older, you can develop this. So after the age of 45, it doesn't necessarily have to do with a cholesterol disorder per se, and it's called ARCUS senilius, which is just meaning like that you get old and you get this. But in a young patient, if you see an ARCUS before the age of 45, you really should be thinking about this disorder. There's also something called lipoprotein A, something that's really not recognized very often. Another marker, a cholesterol marker that's different than the ones we talked about. It's not LDL, not HDL, not triglycerides, a different marker that is similar to LDL, but it also has this component on it that makes it more likely to cause clotting. So what is it? It actually is a separate, independent causal. It really directly causes cardiovascular disease, and it's genetically transmitted. So what does it lead to? What we call myocardial infarction, which is heart attack, stroke, blockages in the arteries, and even premature aortic valve stenosis. So sometimes when we see patients with disorders earlier than what we would have expected for their age, we start to think, okay, what is it genetically that predisposed them to have this? And so when we see patients in their 50s and 60s or 70s, or I say 50s and 60s with aortic valve disease, we think of congenital diseases like bicuspid aortic valve, where there's a lack of one of the cusps that's sort of fused. And we think about this called lipoprotein A elevation. And right now there's a number of things that lower it, not significantly, but there are trials now that we're participating in where we are targeting with a very focused antibody to lipoprotein A to see if lowering lipoprotein A will prevent these different disorders from occurring. And why is it important to know about this and to screen and to check this in patients? Because one, if you recognize it in one patient, you can screen their family members and you can have them get their cholesterol numbers under control at an earlier age to prevent disease. Two, we target their LDL, their cholesterol, even more aggressively. We treat them more aggressively. And three, we will know that those patients are eligible when these lipoprotein A targeted therapies are then available in the market 3, 4, 5 years from now, that they have a treatment that may benefit them. So these are really fascinating parts of cardiovascular disease for me, because really, instead of treating things at a late stage when we've already missed the boat, we could really do something way in advance. It's also fascinating to think about the interplay between how much genetic risk there is and how much environmental risk there is. It's also interesting that your environmental risk, or even literally they've shown that eating a Mediterranean diet, for example, when they look at your telomeres on your genes, that actually alters your genetic makeup. So what you were born with genetically is altered by your lifestyle, if you can imagine. So there's really a complex interplay here. And a lot of patients say to me, well, if I was born with this risk, who cares? I'm destined to have heart disease. Does it even matter whether or not I do anything, lifestyle wise? Well, yes, it does matter, actually, quite a bit. And the truth is that you can substantially reduce your genetic risk with a good lifestyle. But there's also patients who are starting with a very low genetic risk that, because of a very poor lifestyle, end up developing cardiovascular disease. So it's extremely important. When we talk about diet is the leading factor related to mortality in the world. These are data from throughout the world, a global data set showing that, particularly for cardiovascular disease, which is in red, essentially diets that are high in sodium, low in whole grains, low in fruits, nuts, vegetables, those are the ones that are highest in terms of their link to cardiovascular disease. And this is true across all sociodemographic indices. This is not something that is specific to a specific group. This is prevalent throughout the world and through all classes of people. Some other information in a recent publication that we've sort of known about, but I think not enough attention gets put on this, is that ultra-processed food is the worst for your health. So I think that, sometimes there's misconceptions that as long as I'm not eating animal products, I'm eating healthy, which is not true. Because if you can imagine, you can have this lovely soda, bagel, and chips right here as your main staples of your diet and be eating non-animal products. But in no way would that represent a healthy diet. I think you could probably imagine that. And a lot of people are eating non-animal based diets in an effort to reduce our carbon footprint, for animal rights reasons, all good reasons. But if you're going to eat non-animal products, I do recommend plant-based diets. You need to eat healthy components of the diet because, as you can see here, this is what we call the hazard ratio, like how much greater risk do you have by eating these types of ultra-processed foods. And you can see that for a number of very significant things, cardiovascular disease risk, and even mortality, you really do have a much higher risk if you're eating these types of processed foods. But the whole diet discussion is heated, okay? So I like this cartoon. Our menu is divided into 3 sections: cancer-causing foods, artery-clogging foods, and foods that are being boycotted for political or environmental reasons. Really explains pretty well where we're at, because there's so much controversy here. And, for our patients particularly, it gets really confusing. But we do have some very strong evidence for what we call dietary therapy. So there is definitely some exciting advanced medical therapies out there. And we are lucky because in the past decade, we have things to treat those very significant genetic disorders. But keep in mind that diet is a specific type of medical therapy. And you're going to see the evidence that we have that for some of it, it's stronger than what we have for medications and for procedures. So this is the Lyon Heart Study, looking at the Mediterranean diet, specifically in patients who have had a heart attack in the past. So they get put into, and this is how we do trials in general, one of 2 groups, and they're told to follow a specific diet. So one is the experimental diet, which is the Mediterranean diet that they had provided for them, a template of what to eat, and supplemented in this particular diet with canola-based margarine. And then the control diet, which essentially was what was typical in Lyon, France at the time. And what they were able to see is that after 5 years, there was a tremendous difference in terms of the number of what we call cardiovascular events, cardiac deaths, or non-fatal heart attacks. And this, interestingly, occurred even though when you looked at these 2 groups at the end of the trial, their blood pressure was similar, their weight was similar, their cholesterol was similar. So sometimes the effects that you see from a certain therapy are secondary to other effects that they cause. But I think, truthfully, from the Mediterranean diet, I think there is a direct component of the dietary nutrients like antioxidants, vitamins, omega-3 fatty acids, fibers, that have direct effects on your blood vessels, on your vasculature, that prevent cardiovascular disease. And this is another study that showed a very similar thing. This is the Preventative study done in Spain, a very large study of over 3,000 patients, where they looked specifically at patients who, again, were given a control diet, and then patients that were given the Mediterranean diet, either supplemented by nuts or by extra virgin olive oil. They actually mailed this to their homes and said, you know what, we want you to eat this regularly with your diets, et cetera. And what they saw, again, is a 30% reduction in the event rates for heart disease. Those are really significant numbers. And for those who do clinical trials and medications and even procedures, we often don't get that much of a benefit when we look at medications and therapy and procedures. So really keep in mind how powerful the effective diet can really be. And when you look back at the data that they have from that PREDIMED trial and you break it down based on how much what they call pro-vegetarian food there is, either vegetables, fruits, whole grains, etc., you can see that your risk of dying, your mortality rate goes down the more you eat vegetables, fruits, whole grains. So such an important message. And I chose to talk a little bit about weight loss just because there's so much out in the media and it's so confusing. And I definitely want all of you, both for your future careers, but also for yourselves to have a little bit of this information. I think I probably did not eat the healthiest of diets in high school. I had misconceptions about what was healthy, and I thought anything that was low fat was going to be healthy for me. Meanwhile, most of it had absolutely no nutrients and no benefits for me. So I've learned a lot, and hopefully this will be good for you. So when we think about weight loss goals as physicians or clinicians, we're trying to make sure that whatever we're recommending to patients is healthy from their cholesterol, their sugar, blood pressure, the health of their arteries, their gut microbiome. Actually, it's been shown that your diet really, really reflects how healthy your intestinal bacteria are that also tie into all kinds of disease states if it's unhealthy. Your outcomes in terms of heart disease, cancer, mortality. But for patients and for people in the population, they want to know, you know what? Am I going to feel full? Do I have energy on this diet? How is my mood going to be? Will I be able to focus? How's my quality of life? How will I look if I do, follow this diet? So these are, we have to make sure these all line up at the end of the day. Now, of course, looking into the media and what's, coming out every day, there's something different, right? So today, this diet is the best diet ever. This diet's the best diet ever. Next, this nutrient, coffee is good, coffee is bad. Meat, there was actually some group that came together and called themselves experts at one point 2 years ago and said, you know what, we do not need to limit our processed or, meat in general. Definitely not what we would find from the actual literature for diet. Not a good conclusion to have come out, but there are people coming out with different hypotheses all the time. And, sadly, the message that comes out is some very short message about this is good, this is bad, this is good, but that doesn't really explain the whole picture. So we have to be really, really careful ourselves and be very critical of what comes out there. And we have to be able to then teach our patients some of these things. There's also an interesting concept in diet nowadays called ketosis. And this is where essentially you go into a state after you have used up all of your carbohydrate supply. You then tap into fatty acids in your body. And this is what we call a state of ketosis. Now, you can get to a state of ketosis in a couple of different ways. One is through fasting. So there is something called intermittent fasting or time-restricted eating. It's become a popular craze also nowadays. And to some extent, this is a basic idea that you can sort of just follow by literally not eating anything, let's say from 8 p.m. until 8 a.m. the next morning, which might be considered just a normal day. But that period of allowing your gut to rest has been associated with a lot of health benefits of decreasing inflammation, of potentially improving your ability of your gut to sort of process a number of different weight losses, improved cardiovascular disease, and even potentially better weight loss. That's one way to get there from this intermittent fasting. Another way is to eat a very low-fat diet or a keto diet. Now, the keto diet on the right is a healthy keto diet. It's very hard to find enough healthy foods that have a lot of fat but very low carbohydrates. But technically, you could use these to get there. What we see in clinical practice, sadly, is a lot of people coming in on a keto diet that looks a lot like what you see on the left here. And the problem with that is that these foods are, one, usually very high in fat, saturated fat, which is essentially tied to high cholesterol, heart disease, et cetera. And animal products in general have something in them that breaks down into a molecule that is associated with heart disease. It's called trimethylamine that gets oxidized in your gut and has been directly shown to correlate with cardiovascular disease. So this is what we really see. This is actually a publication and a series of patients and what exactly happened to their numbers when they were on these diets. But I see this all the time in clinical practice. You see, to some extent, some of these patients had a slight genetic predisposition that made their cholesterol numbers rise even more. But these are, just to keep in mind, LDL cholesterol, the recommended level is less than 100. So when you can get to levels in the 600s, 500s on a diet, you have to think twice about, okay, I'm going to lose some weight in a few weeks for a short term, but then I'm very likely to have a heart attack or a stroke. You have to sort of weigh those balances there. It's just not very logical for us to be promoting this. So what we preach essentially in the cardiovascular community on a whole are the ones that have the best evidence. And truthfully, if you follow a healthy vegetarian or vegan diet, it actually has been associated with significant weight loss. It's actually, again, doing this in a healthy fashion, not with ultra processed foods and things that are not conveying a lot of nutrients. The vegan or vegetarian diet has definitely been associated with a lot of weight loss. The Mediterranean diet, the DASH diet, which is the dietary approaches to stop hypertension. And the truth is that all of these diets are about 70% the same. The key thing is that we just need to be promoting the core components of these diets. And the way I advise, my patients to think about it is, these are the foods that we know are not very good for us, really. Trans fats, anything processed, refined sugars, saturated fats, sodium, et cetera. The ones we know are really good for us are vegetables, fruits, whole grains, nuts, legumes. And then there's others in between. So we want to shift, along the spectrum. It doesn't mean an all or nothing thing. You literally, if you got rid of one of the bad things and added one vegetable to your diet, you could potentially improve your health tremendously. And we convey these messages in handouts that we have for our patients that we want you to include more of these foods and essentially limit or eliminate the ones that are on the right. And I always tell my patients, to be very honest, I intermittently eat ice cream and potato chips, just so you know. But 80% of the time I'm eating healthy components of diet, so they know that this is something that they can work with you and they can actually accomplish. Now, when it comes to women's heart disease, now that you've heard a little bit about my first passion, which is cardiovascular prevention, I'm going to talk just briefly about what the field of women's heart disease is. And it is a unique field. And I love this cartoon just because it explains how, you can see we have studies of fruit flies, mice, hamsters, frogs, monkeys, and men with this condition. But medical research using women as subjects just never occurred to anybody. Fascinating, and it's true. Women were excluded from research trials purposely in the past because they had certain issues that potentially could conflict with doing scientific research, right? So they could get pregnant, which would be a problem because you can't really be on experimental medications if you could get pregnant, right? So that was a problem. There was also the issue that women, at different times of their lives, hormones could affect different things. So menstruation, menopause, other things. So to make their studies seem more clean, as they would feel would be better, they just essentially just use men, no women. But the reality is that we shouldn't imagine that women and men are exactly the same and that they're going to metabolize drugs and they're going to have the same response to things. The truth is that women, when it comes to cardiovascular disease, things that we think about are that they're smaller. Obviously, they have different fat distribution. Our arteries, our coronary arteries are smaller. We metabolize drugs differently. And there's these hormonal effects that we have to start to learn more about and do more research in. We even have different responses when it comes to adrenaline, for example, sympathetic and parasympathetic nervous system and how we respond. There are also a whole host of unique disease states. Of course, the most common thing that women get are the same that we've talked about before, that plaque under the artery that leads to potential heart attack or stroke. But there are also all these unique disorders in women. So women are at risk for what we call spontaneous coronary artery dissection, something that is essentially a tear in the wall of the artery of the coronary arteries. And it is far more prevalent in women. There's also what we call microvascular disease, where the small vessels of the heart, even though the larger arteries might be fine, they may have issues with the small vessels that gives them a problem. And there's things related to, for example, having gotten breast cancer treatments that then put a woman at subsequent risk, and different effects of pregnancy, hormones, et cetera. So we need to think of the sex-specific cardiac risk factors as well. As we talked about before, there are things that occur during a woman's pregnancy that if we pay attention and we realize that they are putting her at risk, we can then prevent heart disease long-term. As we mentioned, autoimmune disorders or inflammatory diseases are more common in women, lupus, rheumatoid arthritis, and those also have to be taken into account. Whether women are postmenopausal treatments. So when it comes to breast cancer, there's chemotherapy, radiation, and there's also hormone suppression treatments that are used to essentially block the hormones that they think caused the cancer to begin with. And all of those lead to higher cardiovascular risk. So this is a field in and of its own now called cardio-oncology. Really fascinating different areas. And one of the areas I find very interesting is this aspect of hormonal states that I think we have not learned enough about. It turns out that some of these syndromes, whether it's spontaneous coronary artery dissection, heart attack, various things, tie in with women very close to their menstruation. The menopausal years where your estrogen goes down tends to show very high cardiometabolic risk. Something called polycystic ovary syndrome is associated with higher risk. So all of these areas are things that we just have not studied enough to date. And lastly, I'm going to very briefly talk about the presence of women in academic medicine on a whole, and specifically cardiology. So, you can see, and you may have heard that in general, there are more women applying for medical school nowadays, and medical school classes, for the most part, are now shifting. This is data from 2018, 2019. I think the numbers are even higher now for the number of applicants who are female. But something happens as you go along and you're going up that ladder, and not enough women are getting to those roles of division chiefs, full professors, department chairs, deans, et cetera. That's a very significant lack of representation as we go further up, something that we have the ability to influence significantly. And then this is from a Healthline report where women have been shown to be significantly underrepresented in the cardiology field specifically. So, the field of cardiology is high paced. It's quite, it's very exciting in a sense, but it can be a little demanding, and some people perceive it as being difficult for somebody who wants to raise a family, or potentially having to come in the middle of the night if somebody was having a heart attack, or various things that I think potentially may have dissuaded people from going into it. So although we see that increase in medical residents going up in terms of female residents, we see that still the field of cardiovascular disease is only 21% female. And if you look at interventional cardiology, which is where you do go in and fix those arteries, it's even lower. It's less than 10% female. And we think that this potentially may tie into the salary gap that's noted between men and women in medicine. Again, these are all interesting findings that we all have the ability to impact, I think, is the key message here. As a matter of fact, you're going to be hearing, I think, next week from my colleague, Dr. Tara Narula, she and I created a bit of a campaign here at Northwell and Lenox Hill specifically because we do actually have a good representation of women in our cardiology division. And we work together and we try to support each other and really build an environment that is promoting women to not only just get into the field, but then to succeed in the field of cardiology. And we are already we've met with the residency programs, the medical school, different hospitals and everything to sort of encourage this. Our next goal was to reach out to high school as well, because we want to start early and making sure people have that message that cardiology is a field that women can excel in and do great in. It's actually, a lot of women are perhaps even more suited because of certain aspects of it that I think they really need to be thinking of it pretty early. And I'll use my personal story just to kind of explain for all of you, both whether you're, from a female standpoint, from a race or ethnicity or background or upbringing kind of idea. If you think there's something that's off limits to you because of where you came from, I would argue that's not the case. So, I came, to my position here from basically having Greek immigrant parents who came to the United States basically when I was born, and they didn't go to college. They opened a business in the South Bronx across the street from Yankee Stadium, at a bowling alley, a very unusual background. But, I basically grew up in the Bronx and played basketball, did all kinds of things that I think shaped who I really am. Helping out at the family business was actually really educational, and I learned so much, both about business, about diversity, about populations. Playing basketball taught me how to be disciplined, how to play on a team, how to lead. But to be honest, I was never really encouraged to pursue medicine. As a matter of fact, one of my classmates at the time said, "Come on, you and I, we can't be doctors." Just like our parents had diners and bowling alleys, and there's no way we're going to go into medicine. That was sort of the mentality that I had heard, growing up. And there were no role models. There were no, forget women. There were no, physicians in my family. But one of my aunts was actually a nurse. And in high school, I volunteered in a nursing home. I saw what it was like to be a part of a medical field and to take care of patients. And it really inspired me. And, one thing led to another, and I got more involved. And just to let you know that I was able, again, through a lot of hard work, let's not, miss that part of the story here, is that you got to work really hard, actually. I'm now, in a leadership position where I'm involved in all the major societies and have leadership roles there, and I can have an influence on what's being done, both through those societies, through legislation that affects outcomes in terms of what's being offered to the public. In our health system, I'm able to design programs for our whole health system. I'm directing cardiovascular prevention for the health system, which is 23 hospitals, 700 ambulatory practices, really great opportunities. And most rewarding, I would say, is just teaching that next generation of cardiovascular preventionists who are going to actually go out and make a huge difference, hopefully, in the world. So I think hopefully you know a little bit about what the field of cardiovascular prevention is, a little bit more about what you should be doing personally to stay healthy. Be aware that essentially there's a whole other field of women's heart disease that needs to be explored more, that we need to become expert in. And lastly, that there are really no limits to what you can accomplish or become. One thing I think I often use this statement that it comes from my Greek background, gnothisafton, which really means know thyself. So, in your high school years and college and whatnot, you're going to figure out what you're really good at, what you're passionate about, what you really want to do. And you should really follow that instinct, because it's going to help you to succeed in whatever it is that you do. And another thing that I think is important, especially as you make decisions in high school and college, is that you need to trust your gut. And you're going to come across things that you're like, I just don't know about that. That really seems a little bit shady. Trust your gut and go with what you feel is, the right thing to do, what's best for you, and use that in all of your decisions. That'll really, really set you on the right path. And reach out if there are things that you guys want to get involved in. We're happy to help. You know, I'm passionate about this, and I hope that more of you end up in medicine, but also hopefully in the field of cardiology. Thank you.
Thank you so much, Dr. Gianos. That was really great. I know there have been questions kind of going along throughout your talk, but I think that, okay, a lot of people are saying thank you. I can monitor it and just throw them out there to you.
It's in the chat?
It is in the chat box, but the chat box has so many people writing in it that it gets a little like murky sometimes.
Sure.
I'll start out with a question I had. So what would you say is your responsibility knowing that you have a family history of cardiac disease? Like, what, other than like eating healthy, like should you like go in for like heart checkups and stuff like that? And on top of that, like, does it matter if it's through the mother or the father? Like, how does that affect you, kind of thing?
Wow, great question. So I would say that it is important to get a comprehensive assessment by a healthcare professional. A preventive cardiologist would be ideal. A general cardiologist may also be okay. An internist to start with. Essentially, you want somebody who's going to take the time to figure out why exactly you are at higher risk. The reason being, yes, diet and exercise and lifestyle are going to be essential no matter what. So those are going to be universal across the board. Everybody who's got a family history should really be working to improve those aspects, and you should get connected to people who can help you there. But separate from that, if you have either familial hypercholesterolemia or you have lipoprotein A, you may need, on top of medical therapy, on top of lifestyle therapy, you may actually need earlier medical therapy to prevent that heart attack or that stroke. As a matter of fact, with patients who have FH, some of them, even if they ate perfectly for the rest of their lives, they just can't clear cholesterol well. So they would absolutely need medication. So that's the reason to really get checked out early and know your numbers.
Thank you. That's super helpful. I'm just scrolling back, trying to grab some questions for you. Okay. So here's one. Is it true that pediatric cardiology is different because it doesn't deal with diet as much, but more birth defect related issues?
Correct. So most physicians who practice pediatric cardiology end up dealing with what we call congenital heart defects. So this, when you're born with a valve that has an anomaly or a connection in your heart that should have closed off in utero, but it didn't. So that's the typical thing that most pediatric cardiologists deal with. Separate from that, very often, I actually collaborate with a number of pediatric lipidologists or cholesterol experts. So they tend to be general pediatricians who then got training, or they're pediatric endocrinologists who go into that field and they learn specifically about the cholesterol issues. Now, because the prevalence of high cholesterol, diabetes, high blood pressure is actually increasing in kids, shockingly, there are more and more, I think, pediatricians becoming expert in these fields. But yes, you could technically, as a pediatric cardiologist, do these areas, but typically it is more the congenital defects that they deal with.
I hope that was helpful to whoever asked that. This is just an interesting one. How do vegans ensure they get all the nutrients they need? So. Great
question. And to be honest, I don't eat, meat or chicken for the past several years. I do still eat fish and a little bit of dairy and eggs, but I sort of always have to make an effort to make sure I'm choosing the right foods to get a balance, that includes enough protein, enough the vitamins, different things. So it does take an effort. For the most part, from a vegan diet, an entirely plant-based diet, you can get all nutrients as long as you're eating a variety of things: green leafy vegetables, whole grains, some kind of protein-based edamame, chickpeas, beans, tofu, etc. If you're eating a variety of these healthy nutrients, you can get everything. The only thing you can't get from a fully plant-based diet is vitamin B12. And that would be something that you would essentially need to supplement, take vitamin B12 supplements.
Should people take those kinds of supplements even if they're not necessarily on a diet like that?
I'm glad you asked that question, actually, just because there's such a craze in the world for supplements and vitamins. And it's pretty ironic, you know, like patients will come in and say, oh, there's no way I will take a cholesterol medicine that you're recommending. I only, you know, go the natural route. And they're taking 15 different supplements actually over the counter, but they will not take a single cholesterol medicine. And the problem is that, you know, the supplement industry is not very well regulated. It is not regulated by the Food and Drug Administration. And when they look back at things like fish oil pills in some cases, sometimes they have things in them that are really not good for your health. For example, some of them are filled with saturated fat they've found, and which makes no sense for a fish oil pill that's supposed to reduce your heart disease risk. So I suggest that patients get nutrients through their diet predominantly. You shouldn't really need to get, you know, things in vitamin form or in, you know, pills unless you're eating a very poor diet. And if you're eating a poor diet, then you're going to have other problems down the line. So I would suggest first that you work with a dietitian and nutritionist. They can one-on-one go through exactly what you're eating, tell you what you might like to replace things and to really improve your diet so that you improve your health overall.
Along with that, Jane asked, with the differences between men and women regarding the diseases and responses to drugs, would there be different aspects of like the diet recommendations that you suggest for females versus males? Maybe other things than like portion size and stuff like that. Is there stuff they should eat more or less of? Could be hormone related as well, stuff like that.
Wow, good question. The main thing I think is that universally, you know, just getting patients, I think, on the same page for the basics, you know, fruits, vegetables, whole grains. Just when you look at the American diet and the number of people who actually eat at least 2 servings of fruits a day, at least 2 servings of vegetables a day, at least, you know, a serving of whole grains, a few servings of legumes a week. So few people actually meet those basic criteria that I think we need to start there. All of us, like, you know, looking at our own diets, looking at, you know, patients, et cetera. But then I think for women, the more specific considerations is like in a menstruating female, maybe getting enough iron. But for that, it doesn't necessarily mean meat. It could be green leafy vegetables, it could be beans, it could be various sources of iron that you can definitely get in a plant-based, you know, or in a animal product. And then, you know, during pregnancy, folate, B12, there's different nutritional needs during pregnancy that, you know, most people are pretty well aware of, meaning like OBGYNs, that they will support a woman. The misconception during pregnancy is that you can eat anything you want in the world and gain 50 pounds and it'll be fine, which truthfully, that's actually tied to worse outcomes and not a healthy thing to do. And then again, in menopause, I think the other consideration for women specifically is bone health. As your hormones go down, you basically can start to lose bone. So resistance training can actually improve your bone health. Any kind of resistance on the bones actually strengthens them. But then otherwise, just making sure to get enough calcium, vitamin D, things like that.
Yeah, that's great. That was really, really great. Okay, so Margaret asked something kind of on a little bit of a different note. How do you go about having conversations with patients centered around weight while still being body positive? It seems hard to find a balance between health risks associated with obesity and also not shaming people for their bodies.
Excellent question. So I actually partner also with a dietitian, but one is, this is such an important aspect of medicine. I happen to have my major in college was psychology. So I find it very interesting to see the psychology behind a lot of these relationships you have with your patient and your interactions. And the reality is, if you are very good at having these conversations and discussing them in a non-shameful way, in a very open, accepting manner, you are more likely as a physician to succeed in getting your patient's risk factors under control. They have shown in studies as well that this sort of patronizing kind of like, not patronizing, but paternalistic kind of, you need to eat more vegetables and you need to exercise and whatever. It doesn't really help, it's really like, you need to get it where the patient themselves is on the same page as you and they want to make these changes. And that's actually where you can succeed. So one thing we talk about with patients is mindful eating, just thinking about, why is it at this moment that I'm eating? Am I hungry? Am I bored? Am I stressed? What is it that's causing this? And having the conversations, you're right, and explaining to someone, I usually say in a very, basic way, look, we can work with you on your weight, because truth is that, if we help you to lose a little bit of weight, we can actually improve all of your different risk factors, and we can, do all these things, but also not, telling them that it's their fault, because really it's not. I think there's a lot of stigma with obesity and being overweight. And if we convey that to our patients, they're not going to do well. That's a great question.
I like that you talked about how important psychology is too. I agree with that. I think that like there's ways of presenting information that can be more helpful versus less.
Yes.
This kind of goes back a little bit. Zach asked, this goes back a little bit to the like misconceptions about like what's good for you and not. He said, you mentioned avoiding processed foods, but is it more beneficial to eat organic or like free range foods? I know I see like free range eggs all over the place. Does that actually make a difference, or is it kind of just like more of an advertising scheme?
I think that if it were definitely truly organically raised and farm range, et cetera, probably true. My family is from a small village in Greece where, when we were little, our aunt would essentially basically kill a chicken for us to eat, essentially for dinner when we came out there. And that was a chicken that was raised on a farm that ate only plant-based foods, and it sort of ate very healthy. And the nutrients in animals that are raised in a healthy fashion and eat a lot of greens actually tie into what they're eating. So that meat will have more B12 and more folate and more vitamins if in fact that animal is raised in a healthy manner. So it is very, very important. Having said that, it's hard to know definitively, because some of the terminology of like, free range, it's like, okay, they can move 5 inches, 10, I don't even know, like chickens, like they say that, certain labels are actually not exactly what you would think they are. When it comes to organic, one thing to keep in mind, there is something called like the Dirty Dozen, or you can look these up online, but certain foods, as you can imagine, an avocado, a banana or whatnot, it's not likely to get as affected by things in the environment, pesticides, et cetera, because they kind of have a covering on them. But others, berries, and certain fruits and vegetables, green leafy vegetables, it may be more important to eat organic. It's hard to know. There's not a lot of very good research to sort of say, okay, people who eat organic versus people who didn't, over time, it's very hard to know for sure, but probably eating certain foods that are organic, that stay clean is healthy.
Thank you for answering that one. So I absolutely like love what you're doing, I think, with trying to like spread awareness about preventative like cardiology and stuff like that. So I think like one of the challenges might be like first giving people that information, but how do you handle things like food deserts and people not being able to like make these lifestyle changes because of money related things or other like problems that arise? Like how do you go about handling that situation?
That's such an important aspect of that. And you're right, we have to be really aware. It almost seems obnoxious for us to sort of recommend things that people don't have the capacity to do. So, during the pandemic, there was it was hard to get exercise in, like gyms were closed and, you didn't really always have resources. You weren't even recommended to be outside that long, whatever. And so I had come up with, whatever I could do, taking my stairs and doing some exercise on the floor and going for walks with people and things like that. So I told one of my patients, just going for a walk. I said, now, you can wear a mask back, at that time, it's safe enough. You can get out there. And she's like, Dr. Gianos, she's like, it's not safe to go for a walk in my neighborhood. Do you know what it's like right now during this pandemic? And I was like, oh, sorry. It didn't even occur to me that what I'm telling her is not even feasible in her neighborhood. But you're right. Some places have no sidewalks. Some have, it's dangerous to be outside. There's a lot of different issues. Cost is always, a concern, which truthfully, it's true that some, healthy foods can be expensive. But the good thing is that if you find out first, if you ask the right questions to understand your patient's environment and where their obstacles are, then you can come up with realistic solutions as to how to approach them. So if you can't be outside, then maybe coming up with an exercise routine in your own apartment, if you can get motivated to do that, is important, or taking stairs or doing other things, going for walks with other people, maybe at different times if you think that's safer. Food wise, there are actually resources for affordable, healthy ways to eat on a budget. You can get like canned beans, dried beans. You can get frozen vegetables are actually just as healthy, maybe even more. So there's definitely ways to do all of this. You just have to really find out first what the patient is going through and give the right feedback specific to that patient that takes into account their entire background, really, and what's going on with them.
Hi, Dr. Gianos. I'm sorry, there's some traffic going on.
No worries.
This is more about like you specifically and your journey. And because this is like part of our Women in Medicine lecture series, can you talk about like when it comes to cardiology, some of the things that have been really challenging as a woman in medicine, some things you've really enjoyed about it, being a cardiologist in general as well too, like your favorite and least favorite things about your job? People were asking about that. So
sure. Cardiology is very exciting. It's really like, one is, you do deal with a lot of pretty advanced disease, fascinating sort of disease processes. It can be exciting when somebody is coming in the middle of the night with a heart attack and you are able to basically save their life. There is a lot to it. There's fixing arteries, doing procedures, working on the rhythm of the heart, heart failure. There's so many interesting aspects of it. And for me, like being able to make a difference on a population level with prevention is also really key. So I think the field itself has been really, really rewarding. The challenges, I would say, and it's somewhat related to all kinds of fields. I think that as women, sometimes we get raised in a certain way and culture where we're not taught to be as assertive and to be as proactive and to really push for what we would like in terms of success. So that can really hold us back. And, you don't want women working twice as hard as their male counterparts to get to essentially the same place at the end of the day. You need to teach them really early on how to succeed and how to speak up for themselves and how to really advocate. So I think I've learned a lot of that, just by trial and error over time. But it's been a great, I would never change going back what I decided to go into. I love the field of cardiology and what I'm doing.
Thank you so much for sharing that with us.
Sure.
A couple more questions, but I'm gonna pass it along to another intern working with us. This is Melissa, and she'll go ahead and ask you your next question.
Thank you so much for your time, Dr. Gianos.
Sure.
So another question is, was there a specific event that caused you to choose preventative cardiology, or was it something you learned in medical school, or how did this all happen?
Excellent. So in medical school, thought I was going to be a pediatrician, actually, completely unrelated, but realized that I enjoy conversations with adults, talking about exactly what the root of their disease was, about the psychology behind it, really chatting with them about what was going on with them in their lives. I like that more. And then I had an excellent mentor in residency who got me really excited about the field of cardiology. We would just go to the bedside and read EKGs and look at chest x-rays and examine patients, and really learned a lot about cardiology. So I went into that. And then truthfully, I started off my career at NYU originally for 11 years. And I thought I was just going to be a regular general cardiologist, but little by little, I started hearing from a prevention group that was there about all these different aspects about assessing somebody's individual risk and the genetic part of it and the cholesterol disorders. And I learned little by little about it. And I was like, wow, this puts together all of my passions in one area. So I sort of just ended up, falling in love with the field, but just, out of coincidence, I would say.
Got it. That's so cool. I always hear that, and you may go into medical school wanting to follow one path, and then by the end you end up in a totally different direction.
Exactly.
So another question is, how do you deal with patients who are challenging to treat because of gender or religious beliefs, something like that?
Got it. So yeah, I think we have to be very open, to people's own experience and be sensitive to it and respectful to it, and accept the fact that we're not necessarily, our goal is not to change people's beliefs to what our beliefs are really. So you may have people, so one, we take care of a lot of patients who are transgender just because we are across the hall from a transgender center. So it's actually a fascinating thing to learn then about how hormones affect not only the same sex, but then the opposite sex when you administer them, and the cardiovascular effects, and we're doing different research. But you always have to be respectful of, what each different person could potentially be dealing with, on a psychosocial level based on their own experience, from their race, their ethnicity, their gender, their sexual orientation, all of those different things, and sort of take them into account when you're meeting with them. In the middle of the pandemic, I feel like there's a lot of politics that came out. And sometimes you'd come into a room and a patient was going off about what was going on politically. And it may or may not have been on the same page as what you believe, with respect to politics. But your job really is to work with that patient on what you can to improve their health. And you have to kind of keep that in mind, respect their views, and work with what they are actually dealing with.
I am back. Hello. Dr. Gianos, I want to be conscious of your time. And it's because it's 10:01, and we have our virtual OR coming up next, but you fielded those questions brilliantly. I think that people got a lot out of this. Do you mind throwing your information in the chat box again of your Instagram and stuff like that? I know some people had missed it.
Sure.
And and then this video will be, hopefully you're okay with this, it's been recorded and it'll be posted to our YouTube so people can watch it that weren't able to be here live.
Absolutely. The whole point is to get the word out and to let people know that these are great fields. Like I said, I may have never ever gone into them if I wasn't sort of exposed in some way. So I'm glad that your program starts people off really early in high school so that they know everything that they have the capacity to do in their lives. And I hope more and more people go through this. So thank you. Thanks for having me.
Yes, thank you for being here with us. I know everyone's really, really appreciative.
No problem.
And you are all set to go.
Right.
And we will go on to our next segment.
Awesome. Thank you. Have a good day, everyone.
Thank you so much.
Bye. Bye-bye.